Thank you very much to the organizers and to Hans in particular. I actually consider myself to be a Southeasterner, being as I was born in Florida, Baghdad, Florida, actually. Grew up in Mississippi and went back to school at Florida State, so it's good to be back. All right, so I'm going to give you what's new in newborn screening. This is about the umpteenth version of what's new, so I've got it July 2010, so you'll know it's now. And what I want to do is go through some of the things that are happening at the national level and tell you a little bit about what our center does, because as I look at the audience, I don't recognize and don't know many of you. That means that you probably don't know what my center even does. So the National Newborn Screening and Genetics Resource Center is a cooperative agreement with HRSA, and this is wording taken from our grant guidance. We're supposed to be a central informed contact point for newborn screening and related genetics information, assistance, and direction. So we're supposed to be where you go for information about newborn screening. We may not have the answer, but we should be able to direct you to who does. And we do things like technical assistance to programs, resource development, education, and so on. So we're in Austin, Texas. We're part of the University of Texas system. And our infrastructure looks something like this. We have an officer at HRSA who you heard yesterday, if you were here, Sarah Copeland. And our office in Austin has me and 2 or 3 other people, and we have an executive advisory committee of geneticists and some people from CDC and HRSA. We have technical consultation teams that go out to states on invitation and assist them in refining their newborn screening program or their public health genetics program. And if the federal government needs some assistance with white papers and advice, then we are the ones who will pull together project advice committees. And sometimes if there's enough money around, we'll even have some subcontracts. And I'll talk more about that as we go on. So this is us. The biggest project that we have is maintaining the national data system. So we're the place where all state newborn screening programs voluntarily, and they all do this, voluntarily report their data in terms of numbers tested and so on. So we have in our database, which is available to the public online, listing of the conditions that are screened in each state, a summary of the laboratories that do the screening in the state, summary of the age of babies at time of screening, the total births listed by race and ethnicity that comes from the National Center for Health Statistics. We keep up with the percentage of unacceptable specimens in the programs, including first and second specimens. We keep up with the number of newborns that are given an initial screening test, that are given a second screening test, the amount of the program fee, how it's collected, what it's used for, the methodology that the states use for the conditions and what their cutoffs are, their definition of what an abnormal is. We keep up with the program's definition of what a condition is. So we want to collect back from the program's case data, and we found a long time ago that if you set a definition out there and ask states to use it, they usually won't report their data to you because it's not their definition. So what we thought we would do is drive consensus definitions by putting the states' definitions out there in a table. And the states would look at each other's definition and say, oh, that's a good definition. They'd start moving towards one. Well, they did move towards one, but that one is one that says, as defined by specialists. So we didn't get very far with that. Now, that's a big issue, and we really have to address that somewhere, especially if we're going to keep meaningful data on a national level. So there are going to be some efforts in the near future looking at defining conditions and at least putting straw man definitions out there and letting people shoot it down so that we can compare apples and apples. Okay, if you go to our website and go to our information system, it's just newly been updated, and there are some information tables shown on the front page that were intended to spur programs along to give us information. So, for instance, this, you can't read it very well, but this little chart down at the bottom on the right actually says, this is the last time we saw you here. And that's to help programs be motivated to put data on in a timely fashion. And so You may not be able to read the top one there, but it's one from this region that's been out the longest and hasn't put data in. So when that happens, it's usually because they're putting data in on an annual basis or a semi-annual basis. This database is actually set up so that data can be put on as cases are determined, so in real time. And that's what we want people to do. In fact, we're moving towards automated downloads from their databases, and the manufacturers of the data systems are beginning to create that software and provide it to the state. So we'll be getting closer and closer to real time as time goes on. Anyway, I invite you to go visit that database, and there will be a website address at the end of the presentation. So let's talk for a minute about what's going on in terms of definition of diseases that should be screened at the national level. I'm sure you all know there's not a national newborn screening law. Every state has its own. So there are 51, if you count D.C. as a state, 51 programs in the United States. Like 51 separate countries in a way. And at the national level, there is a Secretary's Advisory Committee on Heritable Disorders in Newborns and Children. And that committee accepted a report from the ACMG in 2006, which listed out 29 conditions that should be part of a core panel. And since that time, they've been struggling with how to develop and how to determine what other disorders should be on that list. And they basically moved away from the scoring program that was developed in the ACMG to their own system, which is what I'm going to show you now just briefly. So there's a nomination form if you want to nominate a condition to be included in the core panel. Go to the website, which is listed at the top, and go to our website, which I'll show you later, and click off to their website. And this is the form that comes up. And basically what it has is background information, who you are, what you're doing, why you're nominating this condition, what information is there about the condition that you want to put out in the form, all the information about the screening test that you can garner, all the information about treatment that you can list, and then references. Now, this is to begin the evidence-based review process. So I borrowed this slide from Nancy Green at Cornell, and it looks something like this. The nomination form comes in through HRSA. There's an administrative review to see if it meets the basic criteria, if it has all those fields filled out, basically. And if it's not, it's send it back. If it's accepted, it goes to the Secretary's Advisory Committee, and they take a look at it and determine whether or not they want to go the next step, which is a review and prioritization process. So there's a small group of individuals who look through that nomination and do some background checking to see if it's ready to go to evidence review, a more rigorous evidence review process. If they say it is, then it goes to the Evidence Review Committee, who then goes through about a 4, 5, 6 month process of gathering data, looking at all the details, to come back to the committee and give them information about whether this condition is something they should consider for a core panel or not. So as they come back to the Advisory Committee with their report, the Advisory Committee then listens to the arguments, does their own debate, and then makes some recommendations. And they can either decide that it is something that should be on the core panel, or it's not something that should be on the core panel, or something in between. And if they decide something in between, then it goes, they list out what other studies need to be done, and those studies then will be reported back at some point into the nomination process again. And so I know that's kind of a cumbersome process, but that's the way it goes, and I want to show you what they've done so far beyond the core panel that was recommended initially. In the end, they're asking sort of 6 basic questions. What about this condition in terms of improved outcomes? What about it in terms of case definition and information that's known? What about the screening test? What about the clinical validity of the test and the processes? What about the clinical utility? And what about the cost effectiveness? And those are all things that filter into their considerations. They're not given points or anything. It's just where the normal debate goes. After their debate, they will recommend 1, 2, 3, or 4 options, one of those 4 options. And the ones that have been used so far is option number 1, which is put it on the panel, and option number 3, which is sounds good, it's got some good information, but needs some more information. And the debate always seems to focus around whether it's 3 or 4, and it's hard to determine what the difference is between 3 and 4, and it's hard for the committee to determine when they get into their debate process. But generally, they back off to a level 3, which is just something good if we just have more information. So, I'll just show you some of the ones they've considered. Ponte disease has been considered. You've heard a lot about that this morning. And here's the rationale for doing the screening. I'm not going to go through all the words on this. You can read as good as I can talk. But here is what they listed out for the evidence gap. So that's what needs to be done in the future if the committee decides not to put it on the panel, which in this case they did decide not to put it on the panel. Okay? So they said there needs to be more information about the screening test effectively and efficiently identifying the cases. What's the true distribution of infantile versus late onset disease? Do the interventions in newborns with pre-symptomatic or early symptomatic Pompe improve the health outcomes? What about the cost effectiveness? There's not much data out there, and you've heard this morning there's only limited data in the literature on this condition. And what's acceptability of screening to consumers? So basically the information out there was from Taiwan, and the committee decided that there needs to be some more information from the U.S. And in the end they gave it a 3, which means it's not on the core panel. Come back to us with more information later. Okay, they've looked at SCID, and they've actually looked at SCID twice. This is the first time they looked at it. They said, okay, here's the overview of the condition. Seems worth screening. There's a lot of good things that can happen if the baby's screened and these conditions picked up early. There are assays now that are available. But there were some evidence gaps the first time around. No systematic method of case finding exists. Pilot screening programs needed to be put in place. Maybe there was a consortium of screeners that could do that. And the data was lacking on accuracy of screening, feasibility of screening, consumer acceptance, consumer physician acceptance, the value of treatment, and so on. So in the beginning, this one also got a 3. Okay? Now, here's what happens. If people are interested enough, then they go back and they get more and more information. And this one came back, and the 3 was changed to a 1, and it was put on the core panel. So this is the only one that they've really considered that's been put on the core panel. But it was put on the core panel with some reservations. So this is a recommendation that went from the Secretary's Advisory Committee to the Secretary. And they said, put it on the panel, we think it should be there. But NIH needs to fund surveillance activities, HRSA needs to fund educational activities, and CDC needs to work with the laboratories. And if all those things come to pass, then this should be put on the panel. So that's telling the Secretary where the money needs to go. Okay? So that one has been approved by the Secretary. Money is beginning to flow, and states are beginning to screen. And I'll show you more about that in a few minutes. Crab A disease has been looked at. As you know, New York is screening for Crab A, but nobody else has yet started screening for Crab A. A lot of work is being done. There are methods. There was a pilot in place at the time, and there were some evidence gaps identified. So the appropriate ways of identifying asymptomatics with low galactose cerebroside levels who would benefit from bone marrow transplantation, the harms associated with screening, the long-term neurodevelopmental outcomes, and the cost effectiveness. And so that's the evidence that was pointed to. It was also given a 3, and that's the information that's being awaited by the committee at this point. Hemoglobin H disease was just reviewed. And that one for newborn screening programs poses a little bit of a problem because you're looking for hemoglobin parts. In the screening process, HPLC is the better way to screen for that than isoelectric focusing because you need some quantitative values. Not so many laboratories are using HPLC because it's much more expensive than isoelectric focusing. So in the end, data is coming mostly from California. It's right now considered by some to already be on the list as a secondary target, because if you look at hemoglobinopathies, it gives as a core panel sickle cell disease, sickle C disease, and H-beta thalassemia, beta thalassemia, S-beta thalassemia. And then it says all other hemoglobinopathies on the secondary panel. So people would consider this, many people would consider this being the secondary panel. Not everybody does. And so this was a debate at the Secondary Advisory Committee. There were some evidence gaps pointed out. They mostly had to do with very little data except from California. And so as those data are accumulated, this one's probably going to come back. Right now, it's given a 3. And there were some questions that were raised by the evidence review group and given to the Secretary's Advisory Committee. It said, what is the threshold if we're going to move something from secondary to core? What are the potential advantages of such a move? What are the disadvantages of such a move? What are the expectations from newborn screening laboratories and everybody else after such a move? They really didn't get into this discussion because some people on the committee felt like it was not on the secondary panel because the secondary panel was too broad and it didn't specifically name conditions. And so that debate's going to continue, I'm sure. But right now, hemoglobin H is not on the panel. It's listed as a secondary condition. Okay, so here's the review I've just given you. Those things are coming up as a 3. Some things are not making it to review. And so other things that have been nominated, Fabre's been nominated. The preliminary review said there's not enough evidence to really send this one through the evidence review process, so that one went back without a review. Spinal muscular atrophy, the same thing. That one was not reviewed. The determination was made initially that there's just not enough information to review at this point. On the other hand, hyperbilirubinemia was recommended for formal review and is under formal review at this point. And so is congenital cyanotic heart disease. So this committee looks at things not just biochemical tests, but anything that might be screened in the nursery as well. And it's developing the core panel that way. So these are the things that are being looked at right now. They're the things you'll hear about more in the future. Okay, so what are the states actually doing? I want to preface this with a couple of slides that show you what the laboratories look like, because sometimes what's done in the state is determined by the laboratory that does their screening. So here are the states that are using public screening laboratories by contract, the ones that are colored. So you've got the Northwest using Oregon. So all of these states are using Oregon. And you've got the Northeast using Massachusetts. So all of New England uses Massachusetts. Now, in Oregon, that laboratory says, here's our panel, and if you want to use this panel, you can come to us. If you don't want to use this panel, go somewhere else. Massachusetts says, we'll customize our panel. So if you want something different than what we're screening for, just let us know and we'll customize it for you. So there's 2 different fields of thought there. And I've got Pennsylvania sort of crosshatched because they send part of their samples to Massachusetts and part of it to a different laboratory. North and South Dakota use Iowa. Wyoming uses Colorado. And so if you go to Wyoming and you ask about a newborn screening, they really won't recognize the word newborn screening. They'll recognize the term Colorado. You do a Colorado here. Yeah. Okay. So that's the public labs. Now, if you superimpose on that other laboratories that are private or university or whatever, you get this kind of a mishmash, where California has 7 different private laboratories under contract to the state. Utah uses ARUP laboratories for part of the test, and part of it's done at the state, so they actually split the samples into part one place and part another. So does Minnesota. They send part to Mayo, and the state does part. Montana sends part of their samples over to Wisconsin. Indiana contracts with the Indiana University Medical School. And let's see who else. Pennsylvania then uses private laboratory for part of the samples, and that same private laboratory provides services in Nebraska, Mississippi, and the District of Columbia, and parts of Louisiana. Okay, so everybody left in sort of whitish blue is using their state public health laboratory. see there's less than half the states actually are using their state public health laboratories right now, close to half. So in terms of how many conditions are being mandated, this map shows you mandates by law in the states. And the ones with circles are the ones that are providing the 29 core conditions before SCID. Okay, there are now 30 core conditions, but there are 29, including hearing screening. So all of those with the circle are providing the 29, and some may be providing significantly more than the 29. And some states that provide more than the 29 don't have circles. It's usually because they haven't yet mandated statewide screening for hearing. Okay? Sometimes it's because they haven't mandated tyrosinemia type 1, but that's going away now as succinylacetone comes on board. But you can see it's still, there's only 31 states that had the 29 core. And there were actually 3 who were just doing 20 to 29 disorders. And you can look at the Southeast region and see there's only 4 states in the Southeast that actually have mandated the 29 core conditions. What about some conditions that aren't on the list? So toxoplasmosis is screened as mandated in Massachusetts and New Hampshire because New Hampshire uses Massachusetts and they chose to use that test. New York does HIV and also crab A. There are a couple of other states that mandate HIV if it wasn't done prenatally on the mother, but those states really don't watch what's going on. So Illinois is one of those. If you ask them how many HIVs were screened, they can't tell you because they don't really monitor that. And G6PD is being done in the District of Columbia by the private laboratory and parts of Pennsylvania by private laboratory as well. What about SCID and the LSDs? Well, SCID is mandated only in Wisconsin, and it's mandated on a sort of a strange way. It's sort of remandated every year as they have money. So it's mandated now for the second year. Massachusetts, it's on their group of pilot testing. So it's not really mandated on all babies. It's sort of there for research right now. There's a lot of money coming down from NIH for a project to expand this, and so that's about $1 million that's being put into programs in New York and California and Massachusetts, and Texas is working with Massachusetts. So those are the ones that are actually working on SCID right now. The LSDs, you've got 3 states that have mandated 5 LSDs. Those 3 states are Illinois, Missouri, and New Mexico. And they've mandated them on the basis that certain things occur and then those tests will have to be in place. And there's certain things that occur are things like the test is available and the QC materials are available and so on. That's happening right now. So by the end of the year, Illinois will probably be the first online with some of these disorders. And then Missouri will probably follow. And who knows about New Mexico because they use Oregon as their contract laboratory, and Oregon is not doing the LSDs. And we called yesterday to make sure they have no plans of doing the LSDs this year. Washington State is actually in an NIH-funded project looking at 3 or 4 of the LSDs. And so we marked them as looking. So that's sort of what's going on. Now, we did a survey this week to see what states were doing in terms of LSD and SCID, just so I could report to you. And I can tell you that almost without exception, everybody it's not on their radar screen right now because of financial problems. Neither one of the conditions. A couple of states are looking at SCID. So Colorado and Delaware are looking seriously at SCID, but it'll be at least a year. The rest of the states said, yeah, they're aware that SCID's on the panel now. As soon as money's available, they'll probably do something, but right now their advisory committees are just talking about it. So that's where we are. What about fees? Fees don't always correlate well with the number of conditions being screened, but we do keep up with fees. And they run anywhere from 0 in 3 states to 125 plus in 1 state in this region. So Alabama has the distinction of the highest fee right now in the country. Tennessee somewhere in the middle, and most of the regional states are down here on the end. So that's kind of where everybody We took the states that do 2 screens and have 1 fee, and we half their fee, so they're on here like that. Okay, so if you superimpose over that the number of conditions that are being screened and use sort of the same scale, I have a different map that shows you normalized, but I didn't bring it. So if you use the same scale and look at numbers of conditions, you can still see that there's not good correlation with fees at all. This doesn't track that number of conditions and fees at all. And that's because the federal government puts some money into Title V that can be used for newborn screening. And so some states use that and some states don't. And some states use more of it than others and so on. By and large, the fees cover the laboratory in all states, and they cover some other parts of administration and follow-up and education. Okay, so what else is going on that we can tell you about from our center? When I mentioned a while ago that we have funds that sometimes go into subcontracts. Where those funds come from is we have budgeted money to go in and do program reviews and things like that. And if those funds aren't used, then we'll put those in a pot at the end of the year and use those as more money for regional and national projects. So we do quality improvement reviews. This is a map showing you all the states that we reviewed over the years. The ones that are in dark blue are the ones we haven't had invitations from. The ones that are in the pinkish color are the ones we've had multiple invitations from. And what these reviews are is we go in as a team. We'll have about a 4 or 5 member team. We'll go in and address the issues that the program wants us to address from the outside. Give advice, listen to all the arguments internally and externally, give advice, and write a report. And then that state can use that report to improve their program. And it's been very effective in many states. This is just some pictures of the reviews. If the program is interested in mass spec, for instance, we will bring in a mass spec expert. If they're interested in SCID, we'll bring in a SCID expert, and so on. We've done some special reviews on finances, and we bring in different state finance models. We do training workshops. You'll recognize some of the people in this workshop. We've been doing lately workshops on molecular testing because the states, by and large, aren't geared up or have only geared up recently for molecular testing for cystic fibrosis. And so we're using cystic fibrosis as the model. We're getting ready to convert that model over to SCID. But right now we've had 4 workshops on molecular testing. And this was one that was just recently held at CDC and shows you some of the people there. If you look at the upper right, you'll notice this was the first class we had that was 100% female. It just happened. We didn't go pick it. It just happened that way. Okay. And we still are doing a little bit of mass spec work, so there are still some people who have rotated out of the program, and the programs need more help with their mass spec. And we use the Duke Laboratory and Dr. Millington for that process, along with the laboratory in Dallas with Larry Sweetman. We also sponsor topical meetings from time to time on topics of national interest. So recently we sponsored a meeting on hemoglobinopathies in Oakland because there's been so much turnover in laboratories doing hemoglobinopathies that people have lost sight of simple things like nomenclature and why it is we do certain tests certain ways. So we needed a sort of a refresher workshop. So we had this out in Oakland, and we used that also as a way of introducing hemoglobin H and the issues that might come up with hemoglobin H in the future. We've done workshops in the past on LSDs, cystic fibrosis. We'll do one shortly on information exchange. We'll do another one on SCID during this year. So those are the things that are coming up. Generally what we do is we'll fund one person from each state program. And if there's other people that want to come, we ask the state to fund them, or else sometimes the Association of Public Health Laboratories has funds from CDC and they can use that to support laboratory people. We're working at the national level with Secretary's Advisory Committee looking at second screens. There are all of those states in the pink, dark pink, mandate a second screen, and so does Delaware over there on the right. Okay? Now, so people want to know how come it started out and how come this map looks so funny. Those states in the whitish, they don't mandate it, but they recommend it to the extent that people think it's mandated. And so they get about 85% compliance. So for instance, Alabama It's not actually mandated, but people think it's mandated, and they strongly recommend it, so most people do it. It started in Oregon. The second state to do it was Texas, and it was based on findings in congenital hypothyroidism. So we were finding cases at about 2 weeks that weren't showing up at birth. And if you look at those, we feel like you're going to find those cases. Our neighbors started looking at what we were doing, so you can see all the neighbors between Texas and Oregon got invited to do this. And then Delaware was sending their samples over to Oregon for a while. And then when they figured out that if they mandated 2, they'd have enough to open their own laboratories, they took it out from Oregon, mandated 2, and now they do their 30,000 a year instead of 15,000. But anyway, we're looking to see whether this is a good idea or not. Since all of these, this is about 25% of the babies in the country get a mandated second screen. Everybody else does a second screen on some babies, but it's not mandated unless they were screened before 12 hours or 24 hours or something like that. So if this is a good idea, maybe everybody should be doing it. If it's not a good idea, maybe those states shouldn't be doing it. So we're looking retrospectively at data and prospectively at data to see how that actually filters out. Just quickly, I'm running out of time. Let me look at some of the projects here. We've been working with the Secretary's Advisory Committee on the use of dried blood spots, and they're going to have their final say on that this coming meeting in September. We've participated in all their committees, so we look at long-term follow-up issues, education issues, health information issues, and so on. We collaborate with ACMG at their MCC meetings, at their NBS TRN activities, and so on. We also participate in a lot of the activities at ADHL. So we're there, and we know what's going on, and we know who to contact. So if you need something, let us know, we'll help you. Some of the little projects we funded, we funded 3 regions to work on medical food surveys, and that's currently being evaluated and will be published soon out of person. We funded a meeting for the CARES Foundation looking at CAH and whether or not there should be comprehensive clinical care centers, and that paper is now being developed in conjunction with the Locke and Wilkins Society, and that'll be published pretty soon. We've funded Massachusetts to look at their thyroid cases to see, is this perceived increase in hypothyroidism across the country real or imaginary? Is it because of transient cases or what? And they've gone back and they're looking at all their cases to see over time whether there were transient cases that weren't filtered out or whether this is a real happening. And they're in the publication phase as well. We funded Dr. Kemper at Duke to look at Medicaid reimbursement and healthcare utilization for certain conditions in newborn screening, and that's been recently published. We've got a project with Jennifer Puck at San Francisco looking at SCID in the Navajo Nation because they have a higher incidence of SCID, and that work is continuing right now. We're working with Don Bailey on Fragile X and what parents want to know from newborn screening programs if they get into the screening for Fragile X. And that's a 3-year project and is winding down this year. We funded some meetings with Stanford University looking at hyperbilirubinemia, and we're looking to see whether or not they can come up with a project that would demonstrate what the G6PD is a good marker and should be part of the newborn screening program. So you see we've got a lot of activities going on. If there's money available, we'll try to fund projects. We've got one that's just starting up in the Southwest region looking at sickle cell trait and where the educational materials should be distributed, given that more than half the sickle cell traits in the Southwest region are coming from non-African American. Okay, we've also looking at CMV testing in a similar way to SCID testing in Wisconsin. So, just a couple of things that you might want to look at in the literature. Seminars in Perinatology, we just had a special issue of that come out on newborn screening. This is what the table of contents looks like. Dr. Millington has an article. I have a couple of articles. CDC has a couple of articles. It's a good review about what's going on in newborn screening for the past few years. Includes an article with Dr. Zuckerman as well. And for foreigners in the audience, especially I know Jasmine from the Philippines is here, we've also worked with the Philippine program to do some screening over there, and they've just recently published some of the works in the Philippines on newborn screening. There's a new book out called Newborn Screening Systems, and I have some of these in my office, so if there are any of you in the audience, this is really meant for medical students. It's sort of a side reading. And it's all about screening systems, including how to screen babies in the office and that sort of thing, not just about newborn screening. This is what the table of contents looks like. So if you want a copy of that, send me a letter or send me an email and I'll get it to you. And likewise, I have a couple of issues of the seminars and parenting knowledge still available. Okay, so that's what we do. And there's our web address, Genes R Us. If you need anything, Google us, send us a note, and we'll be happy to help you if we can. So thank you. Quick question?
Yeah, we have time for just one. I was just going to ask you if you wanted to make one of your math slides a little more complicated, would be the number of the military establishments and bases who then send their samples to various places. I know in North Carolina, since we have two very large military bases, one of them sends them to us and one of them sends it to Perk and Elmer, because they say North Carolina does not do newborn screening because we do not have screening for G6PD. So there is, that further complication.
Yeah, the military is a different issue, and so are the Indian reservations.
Yes.
Some of them send them across state lines.
Yes.
The problem with the military right now is that they're setting up a national contract. They may have already set it up with Perk and Elmer. And asking all bases to send it there, not just the Army, but all of them, Army, Navy, whatever. And they have to ask for an exemption if they're not going to do that. And of course, that's what the military is known for, is exemptions, so they do that all the time. But anyway, I think that's a good idea, and we'll work up a